Hi, everybody. This is Dr. Gina Siddiqui with CART Clinics, and I have an interview today that I think you guys are going to really enjoy. Dr. Charles Osterberg is a urologic reconstructive surgeon down in Austin. He's been doing that how many years now?
Yeah, we're approaching about 10 years in clinical practice here.
Yeah, and before that, tell us a little bit about where you trained.
Yeah, so I kind of bounced all over. I'm a native Texan, born and raised in Houston. After graduating high school, I moved up to the cold Midwest. I went to undergraduate in Northwestern, just outside of the Chicago suburb area. After Northwestern undergraduate, I then moved downtown to Chicago and went to Northwestern Medical School. In 4 years there, I then moved to New York City to do my urologic residency training at Cornell Hospital on the Upper East Side. That was a 6-year program, and following that, I then moved completely opposite coast, moved out to San Francisco in the Bay Area, did my urologic reconstruction and trauma fellowship at Mark Zuckerberg's San Francisco General Hospital at University of California, San Francisco. That was a 1-year fellowship, and then following that training, I then joined faculty at the University of Texas Dell Medical School, where I've been on faculty now for the last 9 years. I recently transitioned into the private sector and joined a large urology group called Urology Austin here in Central Texas.
That's awesome. So Austin was your first stop after many, many years of training.
It was back to Texas in Austin, which is obviously just a quick drive from my hometown, but Austin's a fun town with a lot of new innovations, both in kind of the tech sector, but also in healthcare as well.
Yeah, for sure, for sure. How far is the drive, Austin to Houston?
Depending on the time of day, it's about 2.5-hour drive.
Okay, not bad. And yeah, I feel like in the Midwest and in Texas, it's more like the drives are somewhat reliable versus like, okay, in the Northeast corridor, it's like you just double it.
You never know, depending on the snow.
Oh, snow, really?
Well, in the Northeast, yes.
Oh, okay. I was like, oh, interesting.
Not in Texas.
Great. Well, you are a really gifted urologist. Whenever we consult with you, we get such high quality, thoughtful answers. I think it would be great for folks listening on the video to just understand what urologic reconstructive surgery is. Personally, I would just love to know how you got into it.
Yeah, so I'll start with your second question first. How did I get into it? Urologic reconstruction was one of the few areas that I just felt upon graduation that I didn't have a ton of exposure to, and it kind of really intrigued me. This field that kind of blends a mix of urologic surgery, but also plastic surgery and some techniques to kind of improve cosmesis and wound healing and so forth. So it was a combination of lack of exposure, interest in the field, and also the field itself is primarily focused on helping men and women get better in terms of their quality of life. And that obviously impacted me immensely. I have family members that have been affected by urologic cancers, and kind of seeing them go through the cancer treatment, which is oftentimes very successful. But then, of course, what happens after the cancer treatment, this phase of survivorship. And in that phase of survivorship is where a urologic reconstruction specialist can really shine and help that patient or man or woman. So what I mainly do on a day-to-day basis is help men and women improve their quality of life and their functionality. People in my field oftentimes refer to our field as functional urology. And this is really the focus on getting men and women back to that baseline level of status that they were at before they were diagnosed with cancer or had a particularly traumatic event, such as a car accident, or potentially maybe they had surgery that led to a complication, or maybe they were treated with radiation therapy that led to some issues. So I find that aspect of what I do very satisfying, being able to improve quality of life with a surgical approach. Yes, of course, I do treat all general urology, from kidney stones to prostate cancer. But again, my main area of clinical and research focus is in urologic reconstruction. So this is really an area that when patients come back and shake my hand and say, doc, my life is 100 times better. I feel like I'm back to where I was before whatever it was that happened. That's really kind of what gets me up in the morning.
Mm, that's really cool. Can you give a kind of classic example, like a very common scenario of people who will come to a reconstructive surgeon, and maybe just also like like a little bit about what is the surgery, like what is done and what
Sure.
changes after that's done?
They can vary, and that's another reason why, again, I love what I do, because the variety of types of things that we see are so different, and I'll kind of rattle off a few examples.
Great, yeah.
So for one example is, say somebody had a traumatic accident, they fell on a bicycle, and they developed what's called a urethral stricture. Urethral stricture, 30% of the time, happens due to some sort of trauma or what we call a straddle injury. The urethra then develops scar tissue, and then they're no longer able to urinate. So we would go in and do a surgery called urethroplasty, and this can be done with tissue and grafts, and it can be fairly technical. But we basically rebuild the urethra and allow them, the opportunity to urinate normally again without any tubes or drains or anything like that. So that's one example. Another example would be a cancer diagnosis. So somebody comes in with prostate cancer, they're treated with prostate cancer surgery, and then that surgery causes them to be incontinent, and so now they're leaking urine. Well, a urologic reconstructionist puts in an implant that can help get them dry again, and that can be a real game changer for men who are really confined to the restroom and having to wear a liner or a pad, and now they're going back to being able to play their favorite sport or being able to travel again without having to carry around a Depends or a continence device. And then another scenario could be a potential surgery that caused an injury to the ureter or to the kidney, and in that scenario we may do a robotic reconstruction where we're doing some sort of operation to rebuild the plumbing from the kidney on down to the bladder. And sometimes we'll use a graft from the inside of the mouth to do that. And again, these are all done robotically. So
From the mouth?
that's correct. Yeah. We use the inside of the cheek called a buccal graft to repair the ureter.
Huh.
And again, all these are done, through minimally invasive robotic techniques.
Yeah, I think actually early in our time working together, I told you about a patient we worked with who had their whole ureter was ripped, basically when a kidney stone was trying to be extracted. And they were presented options of either like their kidney being removed or getting a graft connecting the kidney to the bladder with their intestines. I
That's
suppose
correct.
The mouth is for a smaller piece of
Yeah.
repair.
I mean, it's not uncommon in our field where we kind of stress the importance of length and location of injury.
Yeah.
So in that scenario, the location was the whole ureter, and the length again was the whole ureter. So you are correct, Gina, that a buccal graft would not suffice, and that you'd have to use the ileum to reconstruct a channel from the renal pelvis down to the bladder. And this is what we term an ileal ureter, which again can be done robotically or through traditional open methods.
Yeah. You mentioned an implant for the person who, after cancer, is incontinent. What is the implant? How does it work?
Yeah, there's two main devices out there by companies that we all know: Boston Scientific, Coloplast, etc. And these devices, one of which is called an artificial urinary sphincter. So this is a mechanical hydraulic pump. Part of the device wraps around the urethra to keep it closed, and then when the patient is ready to urinate, he would simply squeeze a control pump, and that would open up the cuff around the urethra and allow urine to pass. The other one, which most individuals, both men and women, are familiar with, and that's called a urethral sling, and this is something that's made out of mesh. Commonly, we think of it in women, after childbirth having leakage, but we also implant these in men after prostatectomy if the leakage is mild.
Interesting. So there's some overlap with urologic reconstructive surgery and like urogynecology. Both do some of those procedures.
There can be, in my world, it's usually a scenario of a fistula between the bladder and, some other gynecologic organ. And that's usually where kind of my expertise is utilized to fix some sort of fistula connection. Again, typically done robotically.
Hmm. You're one of the people who sees a prostate cancer patient downstream of all the treatment. And I think a lot of people in that moment of having the diagnosis and then figuring out next steps, they don't see, several years or several steps ahead. So I'm curious, just on the receiving end of that, if there are, advice or like best practices that you can think of upstream for when people get their prostate cancer, if they decide, if they're considering surgery or not surgery, who's a good surgical candidate. I think about this a lot, in the ER, that you see basically some of the failures of the health system. And if you sort of, when seeing them again and again and again, you sort of formulate like what people before coming to you, if they knew it could potentially help them.
Yeah, I mean, you're absolutely right. Sometimes hindsight's 2020, and when you're in the thick of it and you've just been given a cancer diagnosis, it's tends to be a more expeditious process to get the cancer removed or treated or whatever the case may be. Two pieces of advice, or maybe more than two, but one, obviously, kind of do your homework and do your due diligence, and I think that's really where your services excel, Gina, is providing those patients kind of the necessary resources and tools to seek out information and do that due diligence. So kudos to you and the team for providing those resources. But in my world, that's going to be meeting with your prostate cancer surgeon, meeting with a radiation doctor, understanding kind of the risks of, disease recurrence. Very important to understand the experience of both your treating doctors, as we know that expertise in both surgical and radiation oncology can drastically, improve or, dictate outcomes.
Mm-hmm.
And then, certainly exploring kind of some other options in terms of, is there something in a clinical trial that might be available that may be more cutting edge outside of kind of the typical guidelines for whatever cancer it is we're talking about. And again, I'm sure, oftentimes the services with you guys, Gina, can provide some of those resources. But hindsight is 2020, especially when it's pedal to the metal cancer diagnosis. But I do urge patients to kind of pause and really research what's available out there, both standard of care and potentially something in a clinical trial if need be.
Mm-hmm. Is there a subset of patients who you think are more prone to some of the complications that you see, or a scenario or?
There can be. I mean, certainly, individuals who are undergoing, prostatectomy, who are morbidly obese, are going to have, higher risks of incontinence or potentially erectile dysfunction. That would be one scenario. I mean, I think a lot of it depends on their disease pathology, which, we can oftentimes discern going into surgery with a combination of an MRI plus minus a PET scan to really ensure that the capsular margins of the prostate are clean, or there's no lymph node involvement, or so on and so on.
And for the folks that do come to you with, I guess the main complications of the prostate cancer treatment are urinary incontinence and then erectile dysfunction. Is that right?
Those are the two in that world for prostate cancer survivorship, correct?
And then how are the outcomes in terms of the folks that see a urologic reconstructive surgeon? And then I'm also curious, would you say most people do end up seeing you as a subspecialist or, one of your colleagues, or is there a large group of cancer survivors who basically don't know or access that?
Yeah, in general, if you look through the literature, I would say, the vast majority of men don't need, a urologic reconstruction surgeon to help them in terms of erections or leakage or injury to the bladder or, whatever the case may be. it's definitely a smaller subset, which is great. I would say it's definitely under 10%. But the 10% that do, I think their quality of life is significantly improved depending on, what they need after whatever we decide. But again, it really depends on what their pathologic features are, what their comorbidities are, their experience of their surgeon and or their radiation oncologist. I think all kind of melt together to provide, kind of an optimal outcome.
Mm-hmm. In terms of the people who come to you, the percent who feel symptomatically improved after these surgeries, like what is sort of, I guess, the success rate, to super simplify it, of managing those two complications of prostate cancer?
Yeah, depending on what we're doing, I would say upwards of 90%.
Wow.
Report satisfaction. If you look at the data for men who receive an implant either for leakage of urine or erectile dysfunction, satisfaction rates are over 94%.
Wow.
So these guys are very happy and oftentimes would, state that they would do it all over again, which is obviously a sign that, their satisfaction is quite high.
Yeah. Yeah. I mean, just comparing some of the other specialties in medicine, for example, people who get spine surgery for intractable back pain, or people who have really severe other like GI complications from cancer treatment. I mean, they're not getting upwards of 90% from any medical or surgical management. So, if you're like facing this cancer diagnosis and then you're thinking about like, what if the worst happens and I have one of these complications, it's pretty remarkable actually that for that subset of things that could go wrong, there's such a good prognosis. That's great.
It is great. And again, it's always such a great feeling to have someone come back and, tell me that, now that they're on the other side of things, that, they are really, really pleased and happy, and that their life is kind of back to where it once was.
Yeah. I'm curious what you have seen, if there are any patterns of things that people don't know, that urologists know, that, is just valuable information. Like maybe stuff that urologists would all do, but regular people don't know or think to do.
Yeah, I wouldn't say there's, some, unusual diet that I adhere to every day, or, some unusual sleep, program, or maybe exercise routine that I adhere to that my peers in other fields don't. I mean, the reality is, for us in terms of some of the other stuff, which we haven't covered yet, but ensuring adequate hydration, I think, is probably something I at least say 3 to 10 times a day. And that could be for urinary tract infection prevention, that could be for kidney stone prevention, and a whole host of other things. Ensuring adequate hydration, very important.
Mm. Do you think your peers do more screening for prostate cancer and things like this than people who are not trained in urology?
My peers being other urologists?
Yeah.
Yeah. I mean, prostate cancer screening is kind of, the pendulum has kind of swung back and forth, as you
Yeah.
know. And there's very much a gray area. I mean, nowadays guidelines recommend kind of this shared decision making, and PSA screening doesn't have to be annually if the PSA is low. But yes, if you're coming to a urologist, chances are that they will at least counsel you about risk benefits of PSA screening and for early detection of prostate cancer.
Is there any kind of like kidney stone differentiation you've noticed between sort of like general advice that a general urologist would give and folks who who deal with a lot of kidney stones, or just have exposure with sort of maybe the more refractory or complex cases know to do or think about doing?
Yeah, I think going back to what I said earlier, drink more water.
Yeah. Okay.
I think putting a lemon or lime in your water is high in citrate. Citrate is a stone solubilizer, so adding lemon or lime to your water, I think, is a very easy around the home remedy that we as urologists oftentimes recommend. And then, of course, some dietary stuff that you can certainly Google, but eating foods that are low in oxalate, trying to reduce animal protein, cutting out some of the leafy green vegetables like kale and spinach, and of course, there's a whole stone, protocol type diet available. But yeah, if there's one thing I could say across the board in terms of lifestyle for somebody seeing a urologist, it would be drink more water.
Yeah, yeah. It's interesting, there's quite a bit I've read about this like stone prevention, these dietary modifications. Do you think that their practices are sort of a reactive thing? Like, okay, if you have a history of stones, you've declared yourself that you're someone who produces them, then think about this? Or do you think that any of those are sort of, I guess generally beneficial enough that they make sense as primary prevention?
Yeah, I mean, I think primary prevention is obviously the name of the game. Anybody who's had a kidney stone will tell you that they never want another one again. We know that about 50% of patients who form one stone will form another stone in their lifetime. So certainly, after having that one stone prevention is really important.
Mm-hmm.
But no one wants a stone, and ensuring kind of these healthy lifestyle habits will help prevent it. That being said, I mean, there are individuals that just make stones more than anyone else, even if they are adhering to a stone prevention type diet. There are genetic related stones like cystine stones, and other genetic metabolism related stones. So but in general, the vast majority of stones are preventable, and again, hydration is going to be the key to ensuring stone prevention.
Yeah. It's really interesting what you said about the lemon and the lime. I didn't realize that. So it breaks down the citrate.
Well, citrate obviously being concentrated in citrus foods, lemons, limes, grapefruits, etc., even in Crystal Light. Citrate is a stone solubilizer, and the higher the citrate levels, the less likely it is the stones can precipitate and crystallize. So think of citrate as a stone prevention method. Yeah. And we prescribe potassium citrate all the time. It's just patients tend to be poorly compliant with the medication because it's a big pill. It's taken 3 times a day or more. So other ways to ensure adequate citrate are put that lemon or lime in your water.
Yeah, yeah. I thought you were going to say put the lemon and lime in so that you drink more water. People always, that's like a, thing that moms say to like make the water more appetizing. But
yeah,
when you say the concentration of the citrate, you mean in the urine?
No, I mean in your glass of water.
But the concentration in what will prevent it from precipitating to a stone? Like basically in your GI tract as it's getting filtered through your kidney?
Yes, correct. In the collecting system of the kidney, the citrate levels, which we measure in the urine with a 24-hour urine collection, need to be at an adequate volume to ensure stones aren't crystallizing. So yes, the higher the citrate levels in your collecting system, the less likely you will have kidney stone production.
And citrate stones are the most common type of stone?
Calcium oxalate stones are the most common type of stones, and there's several subtypes: calcium oxalate, monohydrate, dihydrate, but those are the most common kidney stones that we see. Calcium being the other main component in ensuring an adequate level of calcium in the diet, not too little, not too much, is important.
Yeah. And then this is really reaching back to med school, but the vitamin B intake that you have also impacts how much the calcium you're using is basically either being basically productively used in bone or collecting and to be excreted. Is that?
Yeah, that's correct. We, when you look at kind of the biochemistry of the electrolytes in the urine, and then looking at kind of supplements and diet, even somebody who is making calcium stones, we do not recommend restricting the amount of calcium intake or vitamin D intake. So taking a standard daily recommendation dose of calcium, whether it be through a vitamin or through your food, is recommended, and not restricting the calcium that you're taking in.
That doesn't work to prevent that side of the stone formation, basically.
Correct.
We just think that the downsides, the costs are too high to try it.
Right.
Interesting. Very interesting. I think another thing that people kind of always ask about or wish that they, had a smart urologist to, talk through with them is any warning signs about any urologic cancers and sort of things beyond the screening that they should be thinking about or doing on their own.
Yeah, I mean, obviously, the goal is to catch cancer before it's either, spread or in its early infancy phases. And, there's not a specific diet that we recommend, although we do know that populations that consume a Western-based diet tend to have higher rates of prostate cancer than those that are consuming like a Mediterranean or Asian diet. So I always tell my patients really trying to balance out some of the red meat with more white meat or fish, and increase, vegetables and fruit, much like a Mediterranean style diet. In terms of other kind of warning signs, every year when patients are seeing their internist or family medicine doctor, checking a urinalysis, making sure that they don't have microscopic hematuria for bladder cancer screening. And then, like we talked about earlier, kind of your shared decision making around PSA screening. But short of that, the other urologic cancers are extremely rare, those being penile cancer, urethral cancer. Kidney cancer typically is picked up, at least in Western societies, totally incidentally on CAT scan for other reasons. You go into the emergency room and you see you, Gina, and you get a CAT scan for back pain, and then sure enough, they have a renal mass. So there's not necessarily a screening protocol or prevention thing that I can recommend for kidney cancer. So eat a healthy diet, check check for blood in the urine with your family med or primary internist every year, and then share decision making around PSA screening.
That's great. I think another question that people go to urologists hoping to get answers for and have variable levels of success is about sexual health.
Mm-hmm.
I would love, an insider's view from you on what the training for urology is really good at, and sort of like across the board, you can sort of feel that urologists are going to be able to help you with. And then what are some issues or topics that are more niche and might benefit from a subspecialist, or, just like researching to say that, this is a center that excels in this, or these are the urologists who see a lot of volume of this and therefore are going to be more skilled.
Yeah, I mean, in general, any urologist who is coming out of a ACA GME accredited residency and, is an American Board of Urology, board certified urologist, is going to have some level of expertise across the board. Now, we have, subspecialty boards, in particular in the field of pediatric urology. That I typically, if a patient has a pediatric related problem, I strongly urge them to see a pediatric urologist. But in general, across the board for the adult population, if you have a men's health problem, if you have prostate cancer, if you have a kidney stone, the chances are, your urologist is going to take great care of you. Now, you may need a higher level of expertise, and that may come in the form of, a tertiary or quaternary care center that has a cancer center, or potentially, somebody with subspecialty fellowship training. But the reality is, our field is small. There is certainly a need for more urologists in America. And urologists who come out of training, board certified, are all capable of handling things across the board. The subspecialties, you mentioned sexual health. We do have a subspecialty within urology called men's health and sexual medicine. It is typically a 1-year fellowship, and those individuals will really focus on sexual dysfunction, ejaculatory dysfunction, erectile dysfunction, etc. And then along the same vein, we also have an area within urology called andrology, which is basically infertility, but on the male side of things. And that's an individual that is oftentimes partnered with a reproductive endocrinologist on the women's side of things. and they'll focus on, sperm harvesting, IVF, and that sort of thing. And that's obviously a very niche area that typically may not be performed by a more general urologist.
Right. And if you end up needing the services of an andrologist or of a men's health urologist, in both cases, will you actually be able to see that they're board certified in those domains? Those are both like board programs.
Yeah, last time I checked, I do not believe those two subspecialties are a board certified specialty
Okay.
or subspecialty.
Yeah.
Pediatrics is a board certified subspecialty. But yes, those individuals will typically have on, their credentials some indication of fellowship advanced training in those areas with a typical 1 to 2 year fellowship.
Okay, great. That's really helpful. Are there any, from your residency and your time seeing patients, sexual health topics that you feel, there's this gap between what the patient knows or is thinking coming into it and sort of what the urologist can counsel and advise that you would wish, like people knew without even coming to you? It's just something that you wish you could make a PSA for, different PSA.
Yeah, I think that a lot of individuals, patients think that, having erectile dysfunction is kind of a normal process of aging. And it really, there is a little bit of truth to that, but, in general, our field, we kind of think of kind of the erectile function as kind of an overall barometer for your health.
Mm.
And if a patient in their 50s comes in with, mild or even moderate erectile dysfunction, I strongly urge that patient to, go ahead and seek out additional workup from their internist or cardiologist, looking for any sort of other sites of atherosclerotic disease elsewhere, or potentially, having them have an A1C checked to see if there's any, potential neuropathy from uncontrolled, undiagnosed diabetes. So I think in terms of the sexual piece, I would want kind of patients to know that erectile dysfunction is not a normal process of aging, at least in the earlier decades of life. And that if you are experiencing some erectile dysfunction, this could be an indication of something else. The most common of which, 40% of men with hypertension have ED, 30% of men with diabetes have some ED. So collectively,
Wow.
70% of patients with ED have either hypertension or diabetes. So a huge percentage of men with ED. And so again, we think of the penis as kind of an overall barometer of our health.
Wow, 40% of high blood pressure patients. That's crazy.
Yeah.
You said at least not an early age. Is there an age at which it is like considered normal or like you should expect it to happen?
Yeah, I mean, as I tell my 80-year-old patients, you're no longer a teenager, or you're no longer in college anymore. But I certainly have a handful of patients who are in their 80s who are very sexually active, and the erectile function is normal. So it doesn't have to be a disease that's progressive if you're taking care of yourself, you're monitoring your cholesterol, your blood pressures are controlled, your sugars are controlled, you're walking 30 minutes a day, you're eating right, you're exercising. The erections will persist, and you can have a very healthy, intimate sexual life.
Yeah, yeah. I think to wrap things up, at the beginning of our talk, you really distinguished your specialty as something that is about quality of life. And I think that that's such a important framing for a lot of what we're going to be doing in medicine, in the coming century, right? Because we have sort of, as other people have framed it, handled some infectious disease, right? And then we've had some pharmacologic management for some chronic disease, right? And now many people are living longer, but their quality of life is suffering. And I would love to end with some just sort of concrete, more as just like a way we can all think like you think. measures of quality of life, ways that you and your specialty try to track, either just by questions you ask patients or, things you count, some of that quality of life around, just your domain of obviously urologic issues. But I think it's really great food for thought for all of us to think about, how can we, both as doctors and as patients, like think about what's in our control and the quality of our life.
Yeah, I mean, I think you're absolutely right. I think in general, kind of across, the American healthcare system, we're really trying to shift gears to, disease prevention and staying healthy rather than being more reactive in our approach. Certainly with skyrocketing healthcare cost, it's not sustainable. But in general, I would say a lot of this hinges on lifestyle and choosing the decisions in your lifestyle to positively impact your longevity, which will then in turn impact and improve your quality of life. Obviously, there are things out of our control. Our genetics, of course, are out of our control, but our lifestyle and how we sleep and eat and exercise and take care of our bodies and provide that longevity at a high functional quality of life ultimately will lead to a happier quality of life in life in general.
Yeah, totally. Exactly. It has knock-on effects that are beneficial too in the meantime.
Yes.
Makes the journey fun too.
That's right.
When people are having urinary issues or erectile issues after surgery, are there like metrics, things that you try to count, measure? What's kind of like the way that you track progress or?
Yeah, I mean, a lot of this is patient-reported outcomes. So we have, various sexual health inventory questionnaires that patients fill out all the time in my office. We have leakage questionnaires that, can capture how bothersome, and we have, kind of symptom scores that, track progression of disease. And oftentimes, a lot of these patient-reported outcomes, the last few questions are focused on quality of life, i.e., how much does this bother you? How much does this, impact your day-to-day life? And it's not uncommon where we see bother scores on these patient-reported outcome measures that are quite high.
Yeah.
Even if the leakage or erections or whatever the issue is not that severe, it's the bother that impacts people. And I think that's important to distinguish, is that while the condition may not be that distressing or problematic, it's the degree of bother. Yeah. And we know higher bother leads to dissatisfaction, and then dissatisfaction can lead to mental health, depression. I mean, and the list goes on and on.
Totally.
Certainly, again, just to circle back to kind of where we started, if we improve someone's quality of life, I think a lot of those, the outlook of somebody kind of changes, and it's really great to see that light bulb kind of turn back on and get them back to where they were before whatever sort of event happened.
Totally. Is there a way to preventatively measure for kidney stone formation, like check the urine, or like some way to more sensitively screen before the stone is like clinically significant, or anything on the cutting edge there?
Yeah, not cutting edge, I would say. I mean, and certainly not guideline based in terms of, doing a urine panel on everyone in terms of what their risk is.
Sure.
I think it just for a population level kind of really boils down to what we already talked about in terms of, preventative lifestyle things.
Yeah. Have you seen this new attention on nighttime erections due to Brian Johnson, that he measures this as like a sign of aging?
Yes, yes. I mean, we've had various ways to measure nocturnal erections through the years, and I think the device that you're referring to is interesting. But yes, I mean, there is going to be a correlation there for sure.
Yeah. Cool. Well, thank you so much for the time. This was amazing. How can folks find you?
Yeah, great question. The best way to find me / learn more about what I do is just simply a quick Google search. My name is the first hit on Google, and then that takes you directly to kind of about me and then ultimately my practice.
Awesome. Well, can't thank you enough for not just this interview, but all that you do for our patients. So awesome to have you on.